Welcome back. Today we'll be discussing Chapter 36, which covers operations. This is more of a more fun chapter, I think. We're going to be discussing kind of how a EMS call goes from start to finish. And unfortunately or fortunately, however you want to look at it, there are a lot of questions on the New York State EMT exam that cover operations. I think there's like 5 or 6, which for one chapter, that's a lot. So there is a lot of information here that does might not feel like you need to know, but it does come up on a lot of testing. So with that being said, the topics we're going to be covering are preparing for the ambulance call, receiving and responding to a call, transferring the patient to the ambulance, transporting the patient to the hospital, transferring the patient to the emergency department staff, terminating the call. Then we'll touch a little bit on air rescue. So as you can see, this is essentially start to finish, kind of how to do the job. So preparing for the ambulance call. There are 4 different types of ambulances that you might see in your career. They're called Type 1, Type 2, Type 3, and Type 4. I will let you know this is a very popular thing for New York State to want to test your knowledge on. Like I said, a lot of this seems like you don't need to know it, but it does appear on tests. So we're going to talk about each one individually, and we're going to show you pictures in the next couple slides of what they all look like. So Type 1 ambulance has a truck chassis with a modular or boxed patient care area. There's usually a small passageway, not a passageway that you can fit a person through, but you can pass items through. So that is a Type 1 ambulance. Again, we're going to show you pictures of these in the next slides. Type 2 ambulance is just a straight up van. Some people call them van ambulances, so that's a Type 2. A Type 3 has a van chassis, but a modular or boxed patient care area. In New York State, Type 3 ambulances are probably the most prevalent in the entire state. It really depends on where you work. If you work in the Syracuse area, Type 3 ambulances are by far the most prevalent types. And then Type 4 ambulance is a large truck chassis and has complete separation from the patient care area. There could be a small passageway, but most Type 4 ambulances do not have a small passageway. It's a complete separation between the driving compartment and the patient care compartment. So, as promised, here are some pictures of all of them. This is a Type 1 ambulance. As you can see, it has a full truck chassis, and then you have the modular box of patient care in the back. And again, there's going to be a little passageway through there, but not enough to like put a person through, just things to hand maybe a computer or clipboard through. Here's a Type 2 ambulance, which is a van. Here's the Type 3 ambulance, which has a van chassis with a modular patient care area. There is a fixed passageway between there. Most Type 3 ambulances, the passageway is big enough to fit a person through there. Just giving you an idea of how big these passageways are. And here's a Type 4 ambulance. This one, like I said, it has a large truck chassis. A lot of Type 4s are like Internationals, that brand of vehicle. So think like that big, kind of like almost a semi-truck chassis. And this one does happen to have a small passageway through there. A lot of Type 4s have 0 passageway, period. So just keep that in mind. So a little specifics about New York State with ambulance supplies and equipment. In New York State, Part 800 of Article 30 of the Public Health Law is what lists what has to be on every ambulance in the state. This is only a comprehensive list of BLS supplies. So New York State controls the BLS side of things. They can inspect BLS items. ALS stuff is determined by the region that you work in. So if you're in Syracuse, you work in the Central New York EMS or CNY EMS region, and they're who dictate what happens on the ALS side. The state dictates what happens on the BLS side. So just a little differentiation between the two. State covers BLS, region covers ALS. As EMT basics, you are responsible to the state. You're also responsible to your region, but the state is what really controls all the BLS equipment. An ambulance that is found without proper equipment may have its agency cited and fined by the state EMS regulatory agency. This has happened recently. There have been state inspectors that are sitting at the hospitals. You pull in, you transfer your patient over, and then once you come back to your ambulance, you find a state rep that's there to inspect your ambulance to make sure it has all the equipment that is supposed to be on there. That helps keep your agency honest and make sure that there's a standard of care throughout the state. If you're found to be in violation, they can fine your agency for being in violation. The state inspectors also come to agencies and do surprise inspections. So as a vehicle is sitting in the bay, if it is deemed to be in service, it is liable to be inspected at any time. You as an EMT in your agency need to learn where every item is, what it's for, and when it should be used. This covers ALS stuff too. Once you get out to your agencies, you should sit down with a trusted paramedic in that agency and have them go through everything in there so that you know what things are called in case you're asked to grab them. You know what they're used for, so you know what type of situation where you might need to get them in. It is very, very, very important that you know what is on your ambulance. When you come on shift at whatever agency you're at, you need to do a check of your equipment. Different agencies have different requirements for what needs to be checked, but there are some baseline things that have to be done. So a complete check of all equipment should be performed at once a month at a minimum. The reason for that is things expire. Medical supplies will expire. They usually expire on a month-to-month basis. So once a month, you need to make sure that you don't have any expired equipment on your vehicle. When you check for expirations, a lot of expirations, including especially meds, are written like 11/22. So November of 22. When the expiration is written like that, that means it's the last day of whatever month. So that would be, it would expire on 11/30 of 22. I know there's a typo in there because November does not have 31 days. So that would expire on the last day of whatever month it's written. Some have specific days on there. So it'd be like 6/1/23. Then that expires on that day. So just a little notation of expiration dates. When you're doing your checks, especially the monthly checks, take time to deep clean the equipment and do preventative maintenance. This is how you keep your equipment in service for a long period of time. My agency in particular requires us to pull the portable suction units out once a month during the check and run the battery down completely. That way it's not left charging for months and months and months on end without being used, and that would kill the battery. So that's a preventative maintenance thing that we do, is we discharge the batteries so that they stay a little bit more fresh, so they actually get cycled. Every shift that you come in, you should have, again, it's up to your agency what you can do, but at a minimum, you should check the following: the fuel level, the fluid levels, and the tire pressures. If your vehicle can't run, you can't do much. Your emergency/scene lights, your vehicle lights, and your siren. Patient compartments lights, your HVAC units, which having an intact HVAC is part of New York State Part 800, so it is mandatory to have a working HVAC unit. Oxygen tank levels, a lot of times oxygen tanks will leak at the regulator, and so a tank that was good yesterday could be dead today even though you didn't do any calls. The suction functionality, and the AED and cardiac monitor battery levels. That is a very bad thing to show up to a call and realize that your batteries are dead in anything. Most agencies utilize seals to aid in quickly checking ambulances. So if you've thoroughly checked a compartment, you can put a plastic seal around the opening to that compartment that will break whenever anyone opens up that compartment. So that will help say, okay, that's sealed, we know everything in there is good. The downside of that is you have to trust whoever put that seal on did the check properly. That's not always the case sometimes, unfortunately. So try to hold yourself up to a high standard if you're sealing something, and hold your coworkers up to high standards. If you find something that they sealed and it was not in perfect working order, that's something that needs to be addressed. It is critical to replace equipment and clean your ambulance after every call. You should leave that truck in a perfect condition to take the next call. You don't know who might be taking the next call or when it comes in, so you need to make sure that as soon as possible it is restocked and ready to take a call. All right, moving into receiving and responding to the calls. So the first step in the EMS system, we talked about this on day one, was role of the emergency medical dispatcher. So someone calls 911, they are hooked up to whatever 911 center is assigned to their area. So the emergency medical dispatcher will ask questions of the caller and assign a priority to a call. They have alpha through echo level determinants, which we'll talk about in a minute. They will provide pre-arrival medical instructions to callers and information to crews. So pre-arrival medical instructions are just basic, could be first aid or even CPR instructions to hold the patient over until you get there, so that they have the patient or bystander start care. They will then dispatch and coordinate EMS resources based off of a pre-assigned approach, and they will coordinate with other public safety agencies such as law enforcement or the fire department. Some questions that they will ask the caller is, what is the exact location of the patient? What is your callback number in case you get disconnected? What's the problem? How old is the patient? What is the patient's sex? What is the patient conscious? Is the patient breathing? So emergency medical dispatcher codes. We just talked about that for a second, and here we get to expand on it a little bit. So the EMD codes are listed, like we said, alpha through echo. It's a kind of complex system. I don't expect you guys to understand the entire thing from start to finish now, but it will consist of a general complaint number, and then they'll have the alphabetical priority, and then the subdeterminant. So the examples given here are 1 alpha 1 or 6 delta 2. We'll get back to that in a second. So what we want to focus on right now is the priority. So alpha is the lowest priority call, and echo is the highest priority call, and it progressively goes through there. And alpha was determined to be a BLS non-emergency call. So if you have someone who fell down and just needs a lift assist getting up, that is something that a BLS ambulance can handle, and it's a non-emergency situation. So you shouldn't need to use your lights and sirens to get there. If you take a few extra minutes getting there, it should not cause any further harm to the patient. A Bravo is a BLS emergency call. So an example of a Bravo call would be someone who fell down and hit their head. So it's something that BLS ambulance should be able to handle, but if they hit their head, they could decompensate before you get there. So it is an emergency call. Charlie is an ALS level call. That's a non-emergency. So an example of a Charlie response would be a chest pain for someone who is 35 years old. Chest pain requires ALS evaluation. The fact that they are only 35 means that it's probably not going to be a myocardial infarction, but we don't know. So we do need to send ALS, but it's probably they are not going to deteriorate before you get there. So it's a non-emergency call. You don't need to use your lights and sirens. Delta is an ALS level call that is an emergency. An example of a Delta response would be someone with difficulty breathing, requires ALS, and difficulty breathing can decompensate, so it's an emergency response. Then Echo is anything that is a possible cardiac arrest. If the caller reports that the patient is not breathing, it automatically turns into an echo response. Something specific about echo responses is it entitles anyone who is a public responder to go to that call if they are the closest. So it could be any unit, law enforcement could go, a fire department could go. Anyone who is closest will get dispatched to that because the patient is not breathing and they will decompensate very, very, very fast. So urgency is key with the echoes. So that is the letters that's in the middle. Like I said, the first number is just the nature of the call. So the 1 alpha 1, the first one is abdominal pain. Each number corresponds to something and it goes in alphabetical order. So 1 being abdominal pain makes sense because that's high up in the alphabet. And then the last number is just a subdeterminant. So a 1 alpha 1 would be abdominal pain with no extra things attached to it. 6 delta 2, 6 is for difficulty breathing, and delta is the ALS emergency response, and then 2 would be a subdeterminant, such as the patient has a history of asthma. I'm not sure what the exact subdeterminant of that code is, but I'm just trying to give you guys an example. For now, if you get the alpha through echo in there correctly and remember that, that's all I really care about at this point. So when you are operating the ambulance, remember if you crash the ambulance, you can't help anyone and you become a patient yourself and a burden yourself. There was one time I was responding to a reported cardiac arrest call in the middle of winter, and driving there, we were about a mile away. It was 15 minutes away, and we were about a mile away from the call. We hit a patch of black ice. Was not the fault of the ambulance operator at all, but we hit the black ice and we ended up in a ditch to where we couldn't get out. Fortunately, neither one of us were hurt, but that meant that we could not keep on responding. So the next ambulance had to be dispatched, and that ambulance was coming from about 30 minutes away. So this cardiac arrest patient had to wait the 14 minutes it took us, plus the 30 minutes it took the other ambulance. So just keep that in mind. If you crash, then you're not able to help anyone. And like I said, fortunately, we were not injured. Otherwise, it would have taken 2 more ambulances out of service, and who knows how far away they would have been coming from. So keep that in mind. Be a very safe ambulance operator. Some keys that we are looking for safe ambulance operators are be physically and mentally fit, be able to perform under stress. It is stressful operating an ambulance. Have a positive attitude about your ability as a driver, but don't be overly confident. So you can't be overly cautious because that can create issues in itself. Sometimes you do have to drive somewhat aggressively. We are an emergency vehicle driving emergently, but don't be overly confident and take risks. Be tolerant of other drivers. A lot of times people don't know how to react when an emergency vehicle is coming up on them, so don't be too aggressive and cause an accident. And never drive while under the influence of any substance. I put a little subnote that being overtired is just as dangerous as being under the influence of substances. Don't work long hours. Some agencies will allow you to work 48 hours straight. If you are running the entire time and you're too tired to drive, you have to take yourself out of service. Like I said, you can't be a help to anyone if you crash on the way there. So keep that in mind. Don't overexert yourself. Don't be overtired. Never drive while taking prescription medications that can impair your ability to operate a motor vehicle. Never drive with a restricted license. Be honest with your employer about that. Always wear your glasses or contact lenses if required for driving, and evaluate your ability to drive based on personal stress, illness, and fatigue. While you're operating an ambulance, you need to understand the law. An ambulance operator must have a valid driver's license and be required to complete a training program. That is somewhat agency dependent, but I strongly recommend that anyone who is driving an ambulance, at least at the bare minimum, take an EVOC, which is an emergency vehicle operations course, at some point in your career, preferably before you start driving an emergency vehicle. That will teach you all the ins and outs of operating emergency vehicles and all the laws pertaining to that. That is not part of this EMT basic class because you're not required to drive to be an EMT basic. So we're just touching on this. You have to take a separate course in understanding the laws and everything regarding operating the ambulances. Privileges granted under law to the operators of ambulances apply when the vehicle is operating emergently only. If you are not operating emergently, you cannot take any leeway that the law gives you. So you have to follow the speed limit. You cannot run red lights. You cannot run stop signs. You have to drive like you're driving your personal vehicle. Now, let me say, you have to drive like you're driving your personal vehicle if you're a good driver in your personal vehicle. So remember, you're in a big moving billboard. People see ambulances. They see who you are. If you are driving unsafely, that will come back on you. People are not scared to report what you are doing to agency leadership. Even though certain privileges are granted during an emergency, the exemptions granted do not provide immunity to the driver. If you show negligence while you are driving emergently, you can be held liable for that. Privileges granted during an emergency situation apply only if the operator uses warning devices in the manner prescribed by law. In New York State, that means lights and siren. If you only have your lights on and you don't have a siren on, you are violating the law. So if one comes on, the other comes on. That is something that, especially in country departments, we kind of see that a little bit more. If you feel like you don't need to use your siren, then you don't need to have your lights on. If one comes on, the other one comes on. Most statutes allow parking wherever necessary as long as life and property are not endangered. proceeding past stop signs and signals, exceeding the posted speed limit as long as life or property are not endangered, and passing other vehicles in a no-pass zone after properly signaling and taking precautions. Again, all these are if you're using lights and sirens in an emergent situation. If you do not have those on, you have to drive with normal traffic. Most statutes also allow for disregard for regulations that govern direction of travel and turning in specific directions without or with proper caution and signals. Laws interpreted by the court are based on using due regard for the safety of others. That's what's going to be brought into question if you cause harm. Were you using due regard for the safety of others, or were you ignoring that? And they also will bring in the knowledge of whether, to the best of your knowledge, if the situation was a true emergency. One kind of fail-safe way to do that is use your dispatch priority. If your dispatch priority was to an emergency, then that's a very clear-cut answer of yes, we believe that we were going to an emergency, or this was an emergency situation. If you're dispatched to an alpha response, which is labeled as a BLS non-emergency, that's going to be a little bit harder to justify. You might be able to point to department policies, but ultimately it's going to fall on you as being in charge of the ambulance of, did you think this was a true emergency enough to put your life and the life of the public in danger to get to? When you are using the warning devices, select the proper voice of the siren. Most sirens have 3 different options. Most sirens have the wail option, which is the one that goes down low and then comes all the way up and then back down low. That one is the safest siren tone to use. That one covers the most frequencies out there, and so you can hear it from the furthest period away. It's very acceptable to only use the wail option on the way to a call, because that one is the safest one to use. Using the horn can augment your siren if you need to get someone's attention. And then having visual warning lights, they should be able to be seen well in the day or night, and you should be able to see an emergency light from a 360 view of the vehicle. You need to be seen from all directions having the red lights on at once. Talking about speed and safety, one of my pet peeves. Again, don't put yourself at risk trying to get to a call or trying to get to the hospital. Whenever you speed, you put yourself at more risk and you put the public at more risk. Speeding also increases stopping distance. So if you're going to the hospital and someone's providing care in the back, if you have a longer stopping distance, you might have to hit a hard brake, which will throw your partner in the back if they're not restrained properly. As a general rule of thumb, really there should be no need to exceed over 10 miles per hour above the posted speed limit. The posted speed limits are there for a reason. They say that is what is safe to drive on this road. Going 10 miles an hour over is pushing that envelope. Going anything over 10 means you're probably driving unsafely for that road. So sometimes there's escorted or multi-vehicle responses. So sometimes police might want to escort you to the hospital, or you're going to a call and there's a police officer in front or behind you, or a fire department vehicle in front or behind you. These do present special challenges. A lot of the public only thinks that one vehicle is coming, so they only pay attention to the lead car. Once the lead vehicle goes past them, they aren't looking to see if there's another vehicle coming behind that. So, and also an inexperienced ambulance driver will often follow the escort vehicle too closely and is not able to make a stop when the lead vehicle makes an emergency stop. Driving emergently is dangerous. You have to make hard stops a lot because people do stupid things in front of you. So you need to let a lot of space between you and the lead vehicle or whatever vehicle is in front of you, so that if they make a hard stop, you have time to react. We really don't want to have any escorts anywhere unless absolutely necessary. If you're going to a call, that's necessary. Everyone has to get there. But if you're going to the hospital, having a escort, not usually necessary. Usually you can do it on your own. So just keep that in mind. Escorts aren't that safe, and whenever you have a long line of emergency vehicles, people might not realize you're there. It's a much more dangerous situation all the way around. So some factors to take into account when you are responding to a call is the day of the week. If this is a weekend versus a weekday, there might be a lot more traffic or a lot less traffic. The time of day will determine a lot of traffic. The weather. New York State is not kind year round. So if there's a lot of snow on the ground and a lot of ice, you might, even if you're going to an emergency call, you might not want to be driving emergently. Because again, if you can't get there, you're no help to anyone. The road maintenance and construction going on, sometimes you might have to take detours. Railroads, if a train is coming through, you are stuck there. You cannot just go through a train coming through tracks. So keep railroad tracks in mind. Bridges and tunnels, make sure you can fit through them. Schools and school buses. This is a hard rule in New York State. You must stop for school buses that have their red lights flashing. The reason for that is the driver of that school bus knows where the kids are. You might not. The driver will turn off their red lights as soon as possible, but they are the ones responsible for those kids' safety. If they feel that the kid is not safe, then they're going to keep those lights on, and you must abide by the school bus lights. So keep that in mind. You cannot pass by a school bus that has the red lights on. When you're navigating to this scene, a lot of people nowadays use GPS. A lot of people pull their phones out. If you are driving, you should not be the one that is having your phone out and looking up the directions. Your partner should be looking up the directions. But really, there is no substitute for having an intimate knowledge of your response area. GPS is not always right, and a lot of times there's a lot of streets called, there could be main street and main drive and main road, and the GPS might suggest one, and you might not realize that that's not the one that you're supposed to go to. So if you work in an area, get an intimate knowledge of the area. Please don't rely entirely on technology. That is a critical part of the job, is knowing where you work. Part of knowing where you work is getting detailed maps of your service area. A lot of times if you have like a trailer park or an apartment complex, something where there's a lot of addresses that are kind of squished together, and especially if there's no rhyme or reason, which unfortunately happens a lot with trailer parks or apartment complexes, there's not much rhyme or reason to numbering. It makes it very hard to find where you're supposed to go. So a lot of times there's very detailed maps that are put in the ambulance that will tell you this is this complex and this is where everything is, so that you don't have to drive around looking for it. If you don't have that, and say you're in a neighboring district that you don't know, if you're in a complex or a trailer park and there's someone walking around, it's okay to roll down the window and say, hey, where is this? There's no shame in asking where something is if you are lost. I'd rather have you get to the patient quicker than try to have pride of not being lost. So just keep that in mind. So just kind of summarizing operating the ambulance and responding, you should really minimize your lights and sirens time. If you ever work with me, I turn the lights on maybe once every 3 to 4 weeks. I really don't like putting myself or my partner or the public in danger unless I really truly feel like us getting there sooner is going to make a difference. Studies show that for most responses, you save less than a minute by turning on your lights and sirens. A lot of patients will not deteriorate in that 1 minute time that it takes you to get there, but you put yourself and the public at such a greater risk of injury if you have them on. So just keep that in mind. Also, wear your seatbelts. Unfortunately, ambulances do have collisions, and if you're not wearing your seatbelt, it's almost a death sentence. Even when you are wearing your seatbelt, the chance of you getting seriously injured is pretty darn high if you're in a collision. But if you don't have your seatbelt, it's a very high fatality rate. And also know where you're going before you respond. Check maps, check your GPS, and be familiar with your response area. You should not be guessing when you're turning while you are operating the vehicle. You should be confident in where you're going. Come to a complete stop at intersections. Even when driving emergently, you have to clear intersections and make sure that they have no traffic, no pedestrians, no animals. You have to come to complete stops and take a look. Make sure that people can see you and you can see them. Don't be a distracted driver. Have the passenger operate the radio, the siren, the GPS, the computer, and other devices. You should be focused on driving. Everything else, your partner can do. There's a reason there's two of you guys in there. Moving on into transferring the patient to the ambulance. So there's a lot of stuff that goes into making decisions of how you're going to transfer the patient to the ambulance. You have to select the proper patient carrying device to get them to the ambulance. You have to package the patient properly for transfer, which is putting a blanket on them, or putting them on a backboard or a scoop stretcher, or something to transport them to the stretcher. You then have to actually execute the movement of the patient in the ambulance, and then get the patient on the stretcher into the ambulance. So packaging the patient, like I just said, it's readying the patient to be moved and combining the patient and patient carrying devices as a unit ready for transfer. So packaging could involve putting blankets on if it's in the winter, or putting them on some sort of device to carry them out. Sick or injured patients must be packaged so that their conditions are not aggravated. So that's where the scoop stretcher or the backboard comes into play. If they have some sort of injury where movement will aggravate their injury, you have to take that into consideration. Before placing the patient on a carrying device, complete the necessary care for wounds and other injuries, stabilize any impaled objects, check your dressings and splints, and make sure that everything is secured and ready to go. When a patient is on a patient carrying device, please use all their seat belts. Make sure that they are safe. When they're on the stretcher, you have to use this shoulder harness on every patient every single time. This is one of my big pet peeves with EMS, is people don't use the shoulder harnesses on the stretcher. If you roll the ambulance and you don't have the shoulder harness on, the patient can very easily slide out of the stretcher. Who does that fall on? Both you and the agency. That's a great way to get sued. So put the shoulder harnesses on. I know that it takes an extra 5 seconds, but it takes 5 seconds. Make sure that's on every patient every time, and then the patient will be safe. So protecting yourself. You are at phenomenal risk when you're in the patient compartment. If you get into an accident, even if you are restrained, your chance of getting hurt is incredibly high. If you're unrestrained, the chance of dying is quite high. So some things you can do to take care of yourself is make sure all equipment is secured. Everything should be buckled down somewhere. The monitor should not be loose, the airway bag should not be loose, the ALS bag should not be loose. Everything should be strapped down somewhere. You should remain seated unless you absolutely have to move. And while you're seated, you should wear a seatbelt and harness if possible. I understand sometimes you have to provide patient care that requires you to stand up and move around. I understand that, it's part of the job, but the vast majority of patients you don't have to do that with. So if you can, sit down, stay secured and buckled in. Moving on to transporting the patient to the hospital. So a lot of times a friend or family member will want to accompany the patient to the hospital. Refer to your agency's guidelines on this. I know post-COVID, a lot of agencies have discouraged family members or friends from coming to the hospital, but if they do, load them into the front of the ambulance. There should be very little reason why they should be in the back of the ambulance with you. Number one, it's much more dangerous for them to be back there if you get in an accident, and secondly, they can get in your way if you need to work on the patient. So unless there is some medical need for the friend or family member to be in the back of the ambulance with you, they should really be riding up front. Make sure that you load personal effects and secure them properly. And sometimes you have to say no to a patient for what they can bring. If you can't secure whatever item they want to bring to the hospital, you can't bring it with you. If they have something bulky like a wheelchair, you can't secure that well in your ambulance, you can't bring that with you. So make that decision based off of whether or not you can secure something. Remember to talk to your patient and let them know what's going on. It's very scary being loaded into an ambulance, and very scary being in an ambulance in general. So talk to your patient. Also, avoid letting patients sit on the bench or airway seat. That's kind of a lazy move that a lot of times paramedics force EMTs to do that to their patients, because then, oh, well, we don't have to clean the stretcher. We won't have to remake the stretcher. The stretcher is the safest place for the patient. They should be on the stretcher and fully secured. If they are on the bench seat and you get in an accident, the chance of them getting hurt is significantly higher than if they are in the stretcher, which is designed to keep them safe. While you're en route to the hospital, make sure you notify the hospital, let them know that you're coming. This is varied depending on which area you work in of how you do it. Some hospitals want you to call them on the phone and talk to them, or call them on the radio and talk to them. Some just want a notification from an app. Now, it really depends on where you work. So find out what the hospital in your area wants for notification. Continue to provide emergency care as required. Use safe practices during transport. Compile all your patient information, so all your demographics like name, date of birth, address, medical history, allergies, all that stuff, and continue your reassessment and vital signs monitoring. Revert back to everything that you've learned during this class. Just touching back on pediatrics, I know a few chapters ago was pediatric emergencies and we talked about this, but pediatrics are oftentimes scared. Having them bring a toy with them is usually a good way to keep them calm, and have the parent in the back will also keep them very calm, especially depending on their age. That is one of the times when having the family member in the back is acceptable and almost necessary sometimes, because it will keep the patient calm, which then will help them medically. Going into transferring the patient to emergency department staff. So a lot of this is dependent on where you work, but as a general rule of thumb, most hospitals want these series of events to happen. So first, you want to assist in registering the patient with the hospital admission staff. So you go to the admission staff and you give them all the patient demographics. They will get them registered and get them into the computer. You will give verbal report to a charge or triage nurse and the room nurse. So charge and triage nurse need a report so they know where to put the patient, but you also should be talking to the room nurse, the one who's actually going to be taking care of that patient. The only time that you can't do that is if you receive explicit permission from the charge or triage nurse that it's okay for you to leave without giving a report to the room nurse. And sometimes the room nurse might be tied up for an hour plus. So in that case, the charge or triage nurse is probably going to be in charge of that patient until the room nurse gets there. Make sure you leave a paper PCR with the patient's nurse. So that is a New York State mandate that you have to have a paper PCR with at least partial information. It doesn't have to be your full PCR, but something paper with limited information of who this patient is, what they're there for, and what you did for them should be with the patient's nurse. That way there is no question as to what happened during the call. Be aware that the patient might go to the waiting room. It depends on the hospital, depends on how busy they are, and depends on the patient's complaint. But if they go to the hospital, or if they go to the waiting room, make sure that you follow hospital policies for these patients in transferring care. As soon as feasibly possible, you need to prepare your full PCR and submit that. Make sure that all the patient's personal effects are transferred to them. It is not great to get back to the station and realize that the patient's purse is still in the back of your vehicle. So make sure you do a once over of the vehicle, make sure that no personal effects are there. Once you obtain your release from the hospital, you need to have some sort of documented proof that they said it's okay to go. Usually that means the nurse signing a form saying that you transferred patient care to them. That way they've accepted responsibility for that patient and said that you have given them full report on that patient. Going into terminating the call. So there are a few things you do after the call at the hospital, and then there's a few things that you do at your station. So while you're still at the hospital, you should quickly clean the patient compartment while taking standard precautions, so having your gloves on usually. Replace expendable items. Exchange any equipment according to your local policy, which could be if you used a backboard and there's another backboard at the hospital, you can take that, or if you use a frac pack and there's another frac pack at the hospital, you can take that. If it's stuff that the hospital doesn't exchange with you, then you're going to have to wait until you get back to the station. Make up the ambulance cot and also place equipment on the stretcher for the next call. It's another one of my kind of personal things. The stretcher, a good made stretcher, should have the airway bag and the monitor secured to it. That way, if you come up to a critical call, you can just pull the stretcher out and you'll have all your equipment except for an ALS bag if you have one available and ready to go. You can always take equipment off if it's a non-emergent call, but you should be preparing to take a emergent call where you need all your equipment right away. So please place your equipment on the stretcher for the next call. It makes patient care a lot better. And then make sure that you have enough fuel for the next call. If you don't, please fuel up. Make a determination if your ambulance can be in service for another call prior to returning to the station. This is generally the case. So make sure that you have all the equipment on the ambulance to be in compliance with Part 800. You have enough fuel to take a call and your ambulance is clean enough to take a call. That way, if you get one on the way back, you can take it. So you have to make that determination. Is this rig going to be in service or out of service? Then follow your local guidelines to inform dispatch when you're returning from the hospital, as well as at what geographical point you are fully back in service. So if you are close to the hospital, where I work at Eves, when we leave the hospital, we are back in service because we are generally going to be the closest ambulance to our district at that point. If you work way out in the country, then figure out at what point are we going back in service. It's usually the point where you are geographically the closest ambulance to your district. That is usually when you should be going back in service. But follow your local guidelines and your agency guidelines for that. Once you're back in quarters, fully clean and sanitize the patient compartment. Prepare yourself for service. So if you're dirty, clean yourself. If you need to change your clothes, you can change your clothes. Replace all expendable items that you use. Replace or refill oxygen cylinders, and replace patient care equipment. Make sure that you carry out the post-operation vehicle maintenance procedures as required, if there are any. Make sure the vehicle is clean, and make sure you complete your paperwork. Remember, in New York State, you have 2 hours from the point that you go back in service to complete your paperwork. All right, just touching a little bit on air rescue. So one of the things you're going to have to do as the EMT in charge is decide when to call for air rescue. There are a few different circumstances when air rescue is necessary. First one is to speed up transport to a distant trauma center. This may be needed for other specialty hospitals such as a cardiac center or a stroke center, depends on the patient's needs. So air rescue genuinely will speed up the transport to a distant center, especially a distant specialized center. Air rescue could be required when extrication of a high priority patient is prolonged, and air rescue can speed up the transport. So one thing you have to think about when you're requesting air rescue is it does take a minute for them to get to you. So in the time that it would take them to get to you, you transfer care and then them fly to the hospital. How quickly would you have been to the hospital if you just went right then? But if there's a prolonged extrication, then while the patient is being extricated, the air rescue can get to you, and hopefully they're there before the patient is fully extricated. And another reason to call for air rescue is when the patient must be rescued from a remote location, one that you can't easily get to the patient. So when you're calling for air rescue, this does vary based off of where you are. If you operate in Onondaga County, the dispatch center will do all this for you. But if you have to call individually for air rescue, say you're in another county where they don't do that work for you, this is what you're going to need to give them. Your name and callback number, your agency name, the nature of the situation, the exact location with crossroads and major landmarks, exact location and description of the landing zone, and if possible, your GPS coordinates. When you're setting up a landing zone, there are a few things you need to take into account. First, you need to think of the terrain. Is this something that a helicopter can fly near? You need to think of major landmarks that they can look for from the air. Remember, it's not easy identifying things from the air as it is when you're on the ground. The estimated distance to the nearest town, and any other pertinent information such as wires. Wires are a huge thing to watch out for because you can see them a lot better than they can. Ditches, and wind conditions. Here's an example of a landing zone. A good landing zone should be about 100 feet by 100 feet of clear area. So a large parking lot usually makes for a very good landing zone. Some things to take in mind are there are very dangerous areas to a helicopter. If you ask any any personnel that work on a helicopter, they will tell you, do not approach us until you're given specific instructions on how to approach us. So you can see here, the back of the helicopter is a major danger area, and the approach area is usually towards the front and the side, but general rule of thumb, they'll get out and they'll come to you and they'll give you specific instructions on how to operate around their aircraft. So again, how to approach the helicopter. Don't approach unless you're escorted by flight personnel. Allow the crew to direct the load of the patient. Stay clear of the tail rotor. You cannot see the tail rotor. That's why the back is very dangerous. So just stay clear from that area. Keep all traffic in keep all traffic in vehicles at least 100 feet away from the helicopter, and be aware of the danger areas. Really, just treat the entire area as a danger area. Going into some chapter review. Remember, secure all your gear. It can become a projectile in a crash. Do not let your patient become a projectile. Use the stretcher shoulder straps. Wear your seatbelt in the front and the back whenever possible. Know the medical and operational reasons for helicopter transport and know how to set up a safe landing zone. Remember, cleaning the ambulance, replacing used supplies and equipment, and readying the ambulance stretcher are important elements the EMT must complete while terminating a call. However, EMTs should be prepared for unusual circumstances to arise. So a few critical thinking questions. First, what equipment should you include in a kit that you carry to the scene? Ideally, you should have everything that the ambulance has in it in all your bags. So you should have an airway bag that has all the airway equipment. You should have a trauma bag that has all the trauma equipment. And you should have an ALS bag if you're equipped with ALS medications and equipment inside of it. How should the equipment be positioned so that you can reach urgently needed items quickly? That should be within arm's reach, especially in the ambulance. So position equipment near you to where you can just kind of lean over and grab it and get to work. That way you don't have to stand up in a moving vehicle. What special items, if any, should be in the kit to meet local needs? So a good thing to think about when you're in New York is you might need to have some warm weather things, so hot packs or blankets or something to keep the patient warm. So that's a kind of a specific thing that your agency will decide beforehand, but just keep in mind that you might have to change what you carry in your bags depending on the season. So that brings us to the end of this chapter. Again, it was more of a laid back chapter of discussing how to actually run a call. At this point in class, you really should have done enough ride-outs to where you got a feel for how calls run. But again, a lot of this information is stuff that appears on the New York State exam. So make sure that you know how to do all this stuff. Make sure that you know how to call for air rescue. Make sure you know the types of vehicle or ambulance vehicles. You'd be surprised what they pull and they ask about from EMS operations. So until next time.